therefore a logic for practical implementation of the common origins of diabetes syndrome and its complications to improve treatment strategies and achieve precision medicine. So you'll get traditional labs and testing. You'll do that in at-risk individuals, and eventually you're going to get specific therapy and markers for addressing the genotype, right? And then we'll pick the right drug for the right patient that address the markers for the genes, beta cell inflammation, insulin resistance. There'll be ways we can do primary prevention. I won't go in detail. We'll screen, identify, and treat prediabetes because these processes start early, beginning at 83 milligrams per deciliter. Rising 2-hour postprandial glucose correlates linearly with coronary heart disease. Mild glucose elevations, fastings over 110, increase mortality in patients undergoing PCI. 70% of patients with first MI have IGT or undiagnosed diabetes. Stress hyperglycemia in heart attacks increases mortality 3 to 10 times. In a large 31,000 patient study without known diabetes, both cardiovascular disease, every 18 milligram deciliter higher fasting sugar associated with a 23% increase in the risk of hospitalization for heart failure. And there's increased mortality in hospital if admitted with stroke. And again, it argues for a change in diagnostic criteria from the current to future to the current pre-diabetic levels. And we'll select agents that preserve beta cell function, treat all causes of beta cell dysfunction, treat abnormalities resulting from beta cell dysfunction. No logic for using agents that decrease beta cell function. And for example, in prediabetes, if you use incretins such as GLP-1 receptor agonist liraglutide, 80% delay in progression to overt diabetes, current diagnosis of diabetes. P-glucosomes, ACT-NOW study, 72% delay in advancing prediabetes over diabetes. Metformin, 30%. GLP-2 theoretical benefits. Triple therapy might be better than Defranzo is often treating people right from the get-go with P-glucosamine, SGLT2s, and GLP-1. We want to avoid hypoglycemia, another argument for getting rid of sulfonylureas. Frequency in hypoglycemic symptoms among patients with type 2, upper left, 50% with any insulin, 25%, 30% with oral agents only. Hypoglycemia on the bottom there has multiple adverse effects on the body. And very important, asymptomatic episodes of hypoglycemia can go unreported, both in type 1 and type 2 diabetes, and what I'm calling all diabetes. And this can be 50, 60% of patients that have unreported diabetes. So in your routine care in the office and in the hospital every day, ask these patients, are they waking up with a headache, a nightmare, a sweat that they didn't go to sleep with? These are often physical symptoms associated in the morning with hypoglycemia that didn't wake them up in the middle of the night. We should avoid hypoglycemic agents. This reminds you that we're going to use, let's say, this egregious 11, combine drugs listed here for each of these effects, use the least number of drugs to treat the most number of mechanisms of hyperglycemia. And this is a good table of the mechanisms involved and their benefits. By the way, you can, I think, get my slide set from MDforLives, but you can request it directly from me, and so you can save all these. There are new drugs, there's old drugs that you'll see being used soon. Sartan, celecoxib, locazepam, ranolazine, but other anti-inflammatories will soon be available. In my practice before I retired, I was using 3 drugs: pioglitazone, incretin, glucagon receptor agonist, and abatacept. And in a lot of patients, and a lot of patients require insulin within 2 years. I had patients 5 to 7 years out after diagnosis of LADA who did not require insulin. So these things really can have benefit. We need better studies. I'm not going to go in detail here, but clearly well-described benefits of weight loss and exercise. So don't forget, quote, routine care of your patients, not just drugs, but in their daily life, diet, and exercise. Bariatric surgery, well shown now to be very beneficial, but by multiple mechanisms. They affect nutrient transit, GLP-1, alter the biome, reduce inflammation, reduce insulin resistance, and improve glycemia and benefit cardiovascular risk. And I submit probably reduce the risk of those other complications. The benefits of GLP-1 and SGLT2s far outweigh perceived risk. For example, if people are afraid of using GLP-1s, it causes nausea. Just tell your patient, stop eating at the first sense of fullness of your stomach, and they tolerate it. It's amazing. So reported risk of nausea, 20%. In my hands, it was 1%, just by emphasizing stop eating for a sense of fullness. GLP-1, people were worried, SGLT2, people worried about groin infections and so forth, but just tell the patients to get the tip of the penis dry before they leave the bathroom. Women wipe front to back, get dry before you leave the bathroom, drink lots of liquids, avoid dehydration, and you'll get all the benefits, which include renal, cardiovascular, heart failure with early use of these agents. And again, this is another table that lets you review the drugs that we have and potential side effects, and how you can keep that next to your desk and use it to pick the right drug for the right patient. In my mind, metformin is not the first line anymore, works too slowly, 20% can't tolerate it, and treats only, really should be 2 mechanisms of hyperglycemia. And then if you, quote, want to use the word first line, well, GLP-1 should be first line, SGLT2s can be first line, pioglitazone, or like the Franzo, all 3. They work fast as insulin to reduce lipotoxicity, but without the risk of hypoglycemia, without weight gain. Cost will not be such an issue. As soon as some go off patent, liraglutide might go off patent in the next year, at the most 2 years, and you'll pick the right drug for the right patient based on the causes of hyperglycemia in that individual and other comorbidity considerations. The myth, most patients with diabetes will eventually progress to insulin, but we showed you why that may have occurred, because of the sulfonylurea story. And then think of bariatric patients, no insulin after 25 years of diabetes and 20 years of insulin. You can get them off the insulin. Most patients dying from diabetes have 20% of beta cell mass, but you can reverse that. And it explains the recent focus on remission and cure that you've been seeing in the literature. So we'll avoid insulin therapy and hyperinsulinemia. Remember, on the left, if you eat too much, you'll get sugar rises, you'll use more insulin, you'll get hypoglycemic, you'll increase your appetite, you'll eat more, and this is a vicious circle for increasing insulin. But we now have newer agents that can decrease glucose toxicity, but without hypoglycemia and with weight loss. And you can see by increasing endogenous insulin, you'll get hyperinsulinemia, hyperinsulinemia, which has all these adverse effects. And we want to emphasize in that slide that I've published on how to take people off insulin, even if they've been on it, by getting people to be on the diet and using these new drugs, SGLT2s and GLP-1s. And it's the obviating the use of insulin in type 2 diabetes article. So go find that if you Google my name or Google Scholar or PubMed. So therapeutic principles across the continuum of care, right drug for right patient. We'll aim for precision medicine, primary prevention, preserve beta cell function, 3 to 4 agents before starting insulin, avoid insulin, and new guideline for any therapy evaluate glycemic benefit, but also its cardiovascular benefit, weight loss benefit. And new EASD guidelines say that not first line, second line therapy, but early combination therapy just came out. We'll have to screen for complications, define early neuroinflammatory changes that are in the retina, but you can't see, microalbumin, microfilament testing. We'll start therapy at the earliest sign. Brownlee's theory says, and in my practice, I always was using benfotiamine, alpha-lipoic acid, maybe use it in all these patients because they have clear ways of reducing multiple pathways that contribute to all these adverse processes. We'll delay the need for insulin, no need for early insulin. If insulin will continue the non-insulin therapy. And by the way, if they've been put on insulin for the wrong reasons, we can get patients off of insulin. There's the article obviating much of the need for insulin therapy in type 2 diabetes. We published that in 2016. So in summary, current classifications of diabetes are inadequate. We'll shift to new classification. The beta cell is the core defect. Decide the patient's disease and treatment course based on their individual causes of metabolic regulation, genes, inflammation, insulin resistance, environmental factors. The same mechanisms that cause beta cell dysfunction cause the complications and the associated conditions, cancer, psoriasis, dementia, NAS, heart disease. And we can then define the processes of care that permit patient-centric precision medicine. We'll be looking at diabetes through a new lens of PRISM. Various mediators, beta cell dysfunction offer opportunities for prevention therapy, research, education. One disease, one core defect. There are a million types of insulin, of diabetes. Each person is an individual. Our empiric now will translate to precision medicines via genomics, epigenomics, proteomics, metabolomics. It's a new way to teach diabetes. I hope I've succeeded in doing that for you today. We'll get the students to think, future research, opportunities for drug design, and this is where I predict diabetes will be in the next 10 years. So we'll end here. Have a great day. Thank you.